this video is going to be on pulmonary embolism. So starting off, what is a pulmonary thromboembolism? It is occlusion of the arteries at the level of the lung by a clot. An important thing to note is that it is not occlusion of the alveoli, it is occlusion of the arteries, that is the pulmonary circuit, the lung circuit by a clot. It is very common and has a high morbidity as well as mortality, so it is important to study it. So where does this clot that is blocking the pulmonary circuit arise from? Usually this arises at the level of the deep veins in the legs. Most common is below the knee, and then it travels in through this venous system into the pulmonary circuit, and I will show that to you in just a minute. In pregnant patients, it arises from the pelvic veins. So just remember P for pregnancy and P for pelvic veins. So why does this clot form? This clot is forming at the level of the deep venous system in the lower limb, but why is it forming? What is the pathophysiology behind it? So the cause is the Virchow's triad, which is basically a triad of three components that tells you if a patient has a high probability of forming a clot. So the first component of this triad is vascular wall injury. Anything that causes the vessel wall to be injured can cause a clot to form. For example, any trauma, any surgery, chemical irritation, or even atherosclerosis. The second component is hypercoagulable state. That is the blood is more likely to form a clot than its normal state. So we say that the blood is hypercoagulable, and this could be because of malignancy, this could be because of pregnancy, this could be in someone who has been on OCPs, that is estrogen therapy, or this could be in other diseases, for example, nephrotic syndrome, or someone who has circulatory stasis, that is that the blood is not flowing, it is static, and it is in one place at more than what it's supposed to be. So this could be because of atrial fibrillation, this could be in someone who has been immobile or has paralysis, or someone who has venous insufficiency. So a clot is forming at the level of the deep veins in the lower limb and is traveling towards the lungs. In what kind of patients should you be suspecting a pulmonary embolism? So someone who's had recent surgery, for example, orthopedic surgery, someone who has been immobile for a long time, for example, someone who's come after a long flight, or someone who's been hospitalized, someone who has thrombophilia, that is, their blood cannot clot. For example, they have factor V mutation or protein C or S deficiency, someone who's pregnant, or someone who has been on oral contraceptives for a long time. So this clot forms at the level of the deep venous system, travels as a thromboembolus through the inferior vena cava to the right atrium, goes into the right ventricle, travels through the pulmonary artery towards the lungs, and then blocks blood to the lungs. This can develop into a life-threatening condition, and you will have to intervene as soon as possible. So how does a pulmonary embolism cause damage? It travels towards the pulmonary circuit and thereby causes no blood to flow, thereby causing no perfusion. So you have ventilation coming in to the alveoli, that is, you're breathing in and air is coming in, but you don't have any blood over here in the pulmonary circuit to match this perfusion. So you have 100% perfusion, that is, nothing is wrong with the breathing, but you don't have any blood to get oxygenated. As a result of which, you have a mechanical obstruction causing decreased perfusion, thereby causing a VQ mismatch. You have 100% ventilation, but you don't have any perfusion. So VQ mismatch causing hypoxia and tachycardia. If around 50% of the vasculature is involved, it may cause pulmonary hypertension, thereby causing right heart strain. So how does a patient present with? Someone who has pulmonary embolism will present with a sudden onset of dyspnea. They will have pleuritic pain. They can have calf or thigh pain and swelling. They can present with cough, orthopnea, wheezing, and hemoptysis. They will also have tachypnea, decreased breath sounds, and jugular venous distension. So if the patient has a small embolism, it might not cause any symptoms and it may go unnoticed. However, sometimes the embolism can be large enough to block the pulmonary circuit at the level of the bifurcation of the pulmonary arteries, and this is called a saddle embolus, and this can also cause sudden death. So how do you diagnose? There's something called the Wells criteria, which helps you score a patient into 3 different categories, that is low, moderate, or high. If the Wells criteria score comes out to be greater than 6, we say that the patient has a higher probability of having a pulmonary thromboembolism. If it is between 2 to 6, you say the probability is moderate, and if it's 0 to 1, you say the probability is low. So what is the Wells criteria and how do you find out the score? So the first component is if the patient has classical clinical symptoms of DVT, pleuritic chest pain, hemoptysis, cough, sudden onset dyspnea, calf swelling, the score is +3. If they don't have any other alternative illness that explains these symptoms, for example, they don't have COPD, they don't have asthma, yet they have shortness of breath and pleuritic chest pain, you add another +3 to it. If the heart rate is greater than 100, you add 1.5. If they have been immobilized for duration of greater than 3 days or have had surgery in the past 4 weeks, you add 1.5. Previous DVT also increases the chance of developing a subsequent DVT, so that adds a score of 1.5. And if they have hemoptysis and malignancy, you add 1 for each of those. Depending on the Wells criteria, you treat the patient. So this is a picture of a saddle embolus. You can see this black discoloration, this black part shows a saddle embolus lodged at the level of the pulmonary artery bifurcation. And this is a picture of a VQ scan, which is used as a diagnostic tool for pulmonary embolism. So what is a VQ scan? A VQ scan is also called a ventilation perfusion scan, and it's performed in 2 parts. In the first part, you use a radioactive material that is breathed in, and pictures are taken to identify the airflow in the lungs. In the second part, a radioactive material is injected into a vein in the arm, and more images are then taken to find the blood flow. So you're comparing the ventilation via breathing in the radioactive material to the perfusion via injecting it into the vein. And this is a normal scan, and over here you can identify parts of mismatched ventilation and perfusion. So if a patient has a very high probability of PE, that is the Wells score is greater than 6, the gold standard test is CT pulmonary angiography. If a CT pulmonary angiography is feasible, you do that, and if it's positive, you have a perfect diagnosis of PE right there and then. However, if it's negative, it excludes PE over there for you. However, if the CT PA or the CT pulmonary angio is inconclusive or it's not feasible, you do a VQ scan, which is a ventilation perfusion scan. Depending on the ventilation perfusion scan, if that is normal, you can exclude PE. If it's low or high, then if it's low, you need further testing, and if it's high, you would have diagnosed PE. If, however, the Wells criteria score comes out to be between 2 and 6, that is, you have intermediate probability of PE, what you do is you measure the D-dimer level, which is basically a fibrin degradation product. If the D-dimer level is high, then you go for a CT pulmonary angio, and then you follow the same pathway as you did for a high score of pulmonary embolism. So how do you treat pulmonary embolism once you've diagnosed it? So you have to ask yourself 2 questions. Is the patient hemodynamically stable? That is, their heart rate and blood pressures are fine. And secondly, if anticoagulation is contraindicated in your patient or not. Let's say our patient is hemodynamically stable. That's the first question. Then you ask yourself if you can coagulate, if you can anticoagulate your patient, or if anticoagulation is contraindicated. If you can go ahead with anticoagulation, you give them a heparin warfarin bridge for 5 to 7 days and then discharge them on warfarin for the next 3 months. If you cannot do anticoagulation in your patient, then you consider an IVC filter. If the patient is hemodynamically unstable and anticoagulation is not contraindicated, you go ahead and give them thrombolytic therapy. However, if they're hemodynamically unstable and anticoagulation is contraindicated, you go for a thrombectomy. That is, you go and resect the thrombus. So management, simple and easy. Anticoagulants, you give both warfarin and heparin together in the start. Warfarin initially produces a transient hypercoagulable state. So you give heparin and warfarin together for the first 5 to 7 days. Long term, you give warfarin for 3 months. And then you can also give them DVT stockings, and there are new alternative agents, for example, rivaroxaban and dabigatran, which are factor Xa inhibitors that are also being used. So this was it. I kept it simple. I hope you liked the video. Please like and subscribe. Thank you.